So today I've been asked to talk about the urinary incontinence treatment network and some of the studies that we've done in that network. Very, it was a very exciting time for me to be able to be a part of that network. It was the beginning of my academic career, and it was right at a time when the NIH was interested in funding comparative efficacy research, which right now they are not doing much of. And so we really feel like we squeezed ourselves in there right at the right time to be able to do this research. So the network, first of all, I have no disclosures other than the fact that I was an investigator for the NIH. The network is no more. It has been disbanded, and it did consist of 9 clinical sites and a data managing center. It had a steering committee that was run by Bill Steers, who unfortunately has passed away, and then subsequently Ann Gormley, and it was funded by the NIDDK and then NICHD, 2 federal organizations in the NIH. It was created in order to obtain a higher level of evidence for the incontinence procedures that we were performing on women for both stress and urge incontinence. And over the course of 10 years that it was together, these 9 sites, we randomized over 2,200 patients. Over 1,200 of those patients underwent a randomized surgery. 1,500 of them underwent preoperative urodynamics, and 1,100 of them underwent postoperative urodynamics. So, and we were able to archive all of that data in the NIDDK repository where it still sits today. So this was a very productive 10 years. And I'm going to start by talking about the first trial that we did, which is called the Surgical Treatment of Stress Predominant Urinary Incontinence trial. And this is affectionately called the sister trial. The goal of this was to obtain level 1 evidence comparing the short and medium term efficacy of safety of the birch versus the sling. Subsequently, we went on to do the Thomas trial, which was retropubic versus transobturator midurethral sling to obtain level 1 evidence comparing the short medium term efficacy of those. We were also able to obtain observational data about the predictors of success and adverse events in all of those procedures. And then finally, at the end, we were able to conduct a proper study looking at the value of preoperative urodynamics in the treatment of stress urinary incontinence. And over the next half hour or so, what I'll do is go through the results of those trials. The first trial is the sister trial. Its primary aim was to compare the autologous fascial sling against the birch copal suspension for overall incontinence. So that would include urgency incontinence, as well as stress-specific incontinence at 24 months. And we designed the trial to have an 80% power to detect a minimum 12% difference between groups at a significance level of 5%. So that was a tricky thing to come up with, and some would argue, is that enough of a difference to really call one superior to the other? But that was the difference that we settled on. Our secondary aims were to compare the 2 procedures with regard to complications, quality of life, sexual function, and satisfaction, and then to look at the prognostic values of some of the testing that we were doing, things like Valsalva leak point pressure, stress testing, pad testing. Why did we choose those 2 procedures? Well, at the time, they were considered the gold standards. And one of the important things about the Urinary Incontinence Treatment Network was that in order to apply for the position, apply to be a site, you had to have a PI that was in urology as well as a PI in urogynecology. It was the NIH's effort to really bring those 2 specialties together. And what we find out immediately upon getting together is that urologists were moving more towards slings, and the gynecologists were doing birches. And so It just happened to be that in the year 2000, when we were initiating the study, there was a lot of talk about the mid-urethral sling, and it was just being done, and the information was just coming out of Sweden, but we just weren't ready to really make that the procedure that we would go to first. And this is just a graph, and it just is an illustrate in Great Britain, for instance. If you can see with the procedures that were being done right around that time of 2000, and you can see that just before the mid-urethral sling is going to take off, and the birch really kind of came down quite significantly. Interestingly, the sling itself did not really change much during that period of time. So it's very important, I think, when you look at this data, to understand who these patients were, because they were a very specific patient population that was not your complex patient. They had stress predominant symptoms, so that meant they could have some urgency and urgent continence, but it had to be stress predominant as measured by the MESA, which is an incontinence questionnaire developed by Dr. Diacono at Beaumont. They had to have at least 3 leaks a day of stress type incontinence. They had to have a positive stress test on exam with a full bladder. They had to demonstrate the mobility of the urethra with the Q-tip test. They could not have evidence of obstructed voiding, and they had to be willing to participate in a random study. So what's important about that you don't see is they did not have to have urodynamic stress incontinence, and they did not have to be a stress incontinence operation solely. So they could have concomitant surgery done at the same time, prolapse surgery. So the other thing that's very important to look at is how success was defined. And as many of you know who are dealing with or reading literature or interacting with patients who have incontinence, this has been a real bugaboo to try to standardize across the field. We decided we would maximally put specifications on incontinence. So we said that in order to be a success in the overall incontinence category, you had to have a negative pad test, no self-reported leakage by a 3-day voiding diary, no self-reported stress type urinary incontinence symptoms on a questionnaire, a negative stress test, and have not had no retreatment for stress incontinence in the period of time since you were last evaluated. And those were measured at 6 months, at 12 months, at 24 months to get that outcome. We also felt like, since this was a stress incontinence procedure, even though patients may think that the incontinence overall, all their incontinence would get better, that were doing the procedures, many of us felt that urge could not be expected to get better. And so we wanted to have a stress specific incontinence definition. These are just baseline characteristics of the patients. I think you'll see that they're fairly wet on a pad test. They had incontinence episodes, but not severely, as one would expect. And they had UDI IAQ scores. They could have had a previous incontinence operation, and 14% of them did. 58% had concomitant prolapse surgery, and a large percentage of them had a mixed urinary incontinence picture, but they were stress predominant. And so we randomized 655 patients, and 520, or 80% of those, completed a full 24-month visit. The results are as was shown here, that the sling was found to be statistically significantly better than the birch in terms of 24-month assessment of incontinence. With those definitions, 66 to 49% with stress-specific success, and then it would drop down to 47% versus 38% with overall treatment success. Satisfaction was much higher than the success rates, And the complications also were seen with the sling procedures than the birch. And as I'll show you in a minute, which complications those were. But I think the thing that jumps out right away, aside from the sling being more effective than the birch by these definitions, is that the satisfaction in both of these is quite a bit higher than what we define as success. If you look at the adverse events, clearly the sling had more voiding dysfunction, as defined by the use of a catheter or the need to take down the procedure, 14% versus 2% at the 6-week mark. The sling had more postoperative urge incontinence, but not statistically significant. And interestingly, they did have a significantly more urinary tract infections, but these infections were really occurring within the first 6 weeks after the surgery. Following that, they were equal in the infection rate. And a lot of that, we think, had to do with the fact that of this voiding dysfunction and the fact that they were using catheters for a longer period of time than the patients with birch. We looked at the predictors of outcomes for the sister trial. We found that the more severe the urge symptoms, they were more likely to fail. Postmenopausal women were more likely to fail if they were not on hormone treatment. Stage 3 or 4 prolapse, more likely. But there were no differences in risks between the treatment groups ahead of time, and there was no risks associated with any of these things that sometimes we in the past have sort of associated with lower risk, lower or a higher risk of failure, including BMI, diabetes, previous urinary incontinence surgery, age, or previous hysterectomy. None of those in a multivariate analysis turned out to be predictors of outcomes. We went on to study these patients out to 5 years. However, unfortunately, we're not able to see the patients and to collect all of the information that we collected in the first 24 months. And so there's this overall success rate is defined a little bit differently. It's defined as no reported symptoms of incontinence on a questionnaire or 3-day diary, and no retreatment of stress incontinence. So we weren't able to do an exam or a stress test in these patients. And what you'll see with I think those effects is that our overall continence rates at 5 years continue to decline, while the sling remains superior to the birch. It was really quite dismaying to think that 5 years later, only 34 and 24% of the sling and birch, respectively, patients were meeting that continence definition. And we redid the data for the 2-year data so that we would have, just using the criterion that we used for 5 years, that definition of success, and recalculated and found that these rates were fairly similar for overall incontinence as they were. So we think that this is really picking up an accurate representation, even though we didn't have the exams. So following that study, we were then faced with doing our next study, and many of us were really interested in the mid-urethral sling. And the obvious choice, because there was a study by Hilton in England who looked at TVT, the mid-urethral sling, and the birch, and found them to be basically equivalent at 24 months, and less complications clearly with the TVT. And so that data was there. And so we felt that the only piece really missing would be the mid-urethral sling versus the pubovaginal sling. But we just couldn't get buy-in from the entire group that patients would be willing to be randomized to those two procedures. And we also felt like it would be more difficult to really keep them blinded to the procedure they had, because of course they would have a different set of incisions. So we decided instead to look, it was right at that time when all of the transobturator slings were coming out, and we really were appalled at the lack of data that was available for those at the time. I think when I first came across it at the AUA, there was one French study or from Belgium that was in French, and there's no English data. I seriously doubt there was any Spanish data, Spanish language data as well. And so we thought that really the time was ripe to compare the retropubic versus the transobturator mid-urethral slings. So we looked at both objective and subjective treatment success at 1 and 2 years for these. We enrolled 585 women. We had a 12-month follow-up in May of 2009, and then we went on to evaluate an e-TOMAS as well. And the data for this was designed as a little bit different than the Birch sling. The Birch sling we felt were equal in terms of their the knowledge that we had about them and that the success rates. We didn't really feel like we could say that one was better than the other and one was not new and one was old. So we could compare those directly with the superiority study. But with this, we said, look, we have a lot of data already on the retropubic sling, but we don't really have good data on the transobturator sling. And so this should really be a non-inferiority treatment protocol to look for a significant difference between these, because it's possible that the transobturator was just not as effective or had a different outcomes, and we didn't know that yet. And so we powered this study to look at the difference at 12 and 24 months between the two procedures, and look for a 12% difference if the efficacy rates or the difference. So these represent differences. The efficacy rates are over here. At 24 months, the retropubic sling is 77% success rate versus 72% success rate. And that difference is 5.1%, but that falls within the confidence interval, thus saying that there is no inferiority between the two procedures. So there was no statistically significant difference that we could say between the two procedures. If you looked at subjective success rates, and that was there was no the difference was even less. So while there was a trend toward a statistical difference, it wasn't statistically significant by what we had defined. We looked at adverse events, and it was interesting because clearly these procedures are different in terms of their adverse events. Voiding dysfunction and requiring surgical treatment or requiring catheter use occurred only in a takedown occurred only in the retropubic. There were 0 transobturators, and use of a catheter occurred more often in the retropubic than the transobturator. Urinary tract infections also trended higher in the retropubic, probably again because of that catheter use. And interestingly, it was neurologic symptoms and pain that were higher in the transobturator group. These neurologic symptoms were not permanent, and by 6 weeks appeared to resolve, but there was clear difference initially. So these are the main differences. Oh, and I'm sorry, bladder perforation as well. As one would expect, it's pretty difficult to perforate the bladder with the transobturator devices. And we allowed use of both in to out as well as out to in, but we did look at those afterwards to see if there was any trending of those in terms of efficacy or a safety, and there was not. But again, the study wasn't powered to look at it that way. So I think what's really important to us, is this quality of life data. And there's a similar graph that looks at the sister cohort. And what you can see is that almost immediately you get a very significant improvement in the quality of life questionnaire score. The largest improvement occurred between the pre-op and the 6-month visit. And what's fantastic about it is even though the failure rates are going up as time goes on, that we see the quality of life and the satisfaction rates remain similar out to 24 months. So we'll talk a little bit about this and what that means in terms of how we're measuring success. But I think I just want you to really remember that graph there. So we'll talk a little bit about when we put these two groups of patients together. Unfortunately, they're not exactly the same cohorts. We didn't use exactly the same measures for success. We have this urge incontinence. We have the overall incontinence, stress-specific incontinence in the sister trial, and then we have the subjective and objective in this trial. But what you can see in both trials is that as time goes on, the failure rates just continue to increase. Fewer and fewer patients remain continent by these definitions with over time. And I think this is, it's very difficult to get long-term 5-year data on all of our incontinence patients because women are mobile. They're moving on, and if they're doing well, they're not going to be interested in coming back for that type of follow-up. Again, satisfaction rates seem to stay high. I think this is a very interesting way to look at the data, and I think it tells us a little bit why these success rates might seem really inaccurate from your own experience, maybe, because it really it depends on how you are defining the failure. So and this is a sister group, and the dark blue is birch and the light blue is sling. And if you just asked people, if you just looked at a pad test or a cough stress test, you would see far fewer failures than you see when you add the diaries or symptoms into the category. And the same goes here with the retropubic and the transobturator slings, is that if you're looking only at the pad test, then the failure rates are quite low. I mean, there's only about 80% of the patients consider themselves successful, or would be successful if we were just looking at a pad test. But when we add symptoms in, or when we add all of these together, where you could fail by one, and that would put you as a failure, then that compounds the problem, and you get these higher failure rates. I don't know that it helps us resolve this issue about how should we be measuring success, but it definitely tells us that it's important how you measure success, and I think graphically demonstrates that quite well. If we look at both of our trials and we say what are the common predictors of failure, higher in sister, it's if you had a higher baseline urge score, you were more likely to fail. If you had more advanced prolapse, you were more likely to fail. And if you were menopausal and not on hormone replacement therapy, you were more likely to fail. Thomas, if you had prior incontinence surgery, you were more likely to fail. If you had lower urethral hypermobility, again, higher urge scores and higher severity of incontinence as measured by pad weights were what factored into Thomas failures. Again, in neither trial was age, diabetes, or BMI associated with higher likelihood of failure. I want to say something about urodynamics, because I think this trial, all of our trials have really provided us with a lot of information about urodynamics. First of all, we were able to obtain standardization and prove that standardization can be done in multi-center trials. We obtained reference values for women with stress incontinence in terms of all of the values that we look for in flow rate and resting pressures and things like that. We were able to assess predictive value of baseline parameters, urodynamic changes after SUI surgery, and with our last study, a value of preoperative urodynamics. And these are all been published, the reference values, the baseline urodynamics of our patients. I think interestingly, you can see that there's 11%, 10 or 11% in the sister trial, 14% in the Thomas trial that did not have evidence of urodynamic stress incontinence and went on to have surgery. Detrusor overactivity, even though 80% of them felt like they had urge symptoms, only 10 to 12% demonstrated overactivity, which was reassuring for us that we were, doing the right operation. And then standard leak point pressures. When we looked at preoperative urodynamics, if they were predictive of outcomes, they were not. Urodynamic stress incontinence that occurred in 10% of the women. In the sister trial, it was predictive, 2.5 times more likely to fail if you had no urodynamic stress incontinence. The one thing that we did not do in that trial, which maybe clouds this issue, is that we did not remove the catheter and retest them without the catheter, because I think you would have picked up more of these patients that had stress incontinence. But we still can't explain that. There was no relationship with whether they had urodynamic stress incontinence or not with the Thomas trial. There was no significance in difference in success rates in either trial if they had DO or did not have DO. And Valsalva leak point pressure and urethral closing pressure, there was no correlation with success in the sister trial. In the Thomas trial, the lower your VLPP or your MUCP was, the more likely you were to fail. It wasn't enough to say you shouldn't have the procedure, but it was just more of a predictor of failure. And then the non-invasive ural flow and the pressure flow parameters were not predictive of success rates either. So were there any voiding symptoms? So UDS variables were not predictive of women failing the first voiding trial after Thomas. So a lot of people have said, well, if they have, abdominal straining or Valsalva voiding, that they're less likely to void afterwards, and we did not see that. And interestingly, but I guess not surprisingly, both the Birch and the pubovaginal sling are associated with increased voiding pressures even 2 years after surgery, which probably speaks to their mechanism of action. But the problem with this is that neither of these trials were designed to really answer the question of whether urodynamics was valuable as a preoperative tool. So this is, first of all, as a highly selected group of women. So right away, you could tell me that, we don't know in patients that are, on their third operation for stress incontinence, or patients that have more urge than they do stress, or patients that have higher post-void residuals. I mean, we did not look at those patients. So clearly 90% of them that had urge symptoms did not have any evidence of detrusor overactivity, and maybe detrusor overactivity in a different population does predict, but we just can't say that. So we wanted to design a trial to try to get at that. We wanted it, because we felt like urodynamics is very expensive, it is invasive, and we felt like we owed it to the large number of patients who were undergoing urodynamics to be able to tell them whether or not it was helpful. So we wanted, that's exactly the question, to determine if in stress-predominant stress incontinence, women who only receive a basic office evaluation versus those that receive an office evaluation and a urodynamics, does the second group have better outcomes? And so to be included in this population, in this study, you had to have stress-predominant urinary incontinence, a positive stress test, a negative UA, a post-void residual less than 150, and desire for surgical treatment. And that was how you were able to get into the study. And then once you got into the study, you were going to be randomized to either receiving urodynamics or not. This was not a randomized trial to therapy. It was a randomized to whether you had urodynamics or not, and then whether that affected any of the whether it changed the procedure, whether I'll show you that in a minute. But what's important about this, and what people tend to forget, or they get all hot and bothered that we're really sort of arguing that urodynamics isn't helpful in incontinence populations, and that's not it at all, because it's very important for physicians as well as regulators and people making decisions about what to spend money on, insurance companies, that we did not include any patients with urge predominant or urinary incontinence, any patients that had previous surgery for incontinence, any patients that had prolapse outside of the introitus, and patients that had pelvic irradiation, or patients with large post-void residuals. So any of those patients, this just simply doesn't apply to. So the results of that trial are simply that there was no difference. No difference in terms of the outcome for in terms of the severity of the incontinence, the quality of life, and the patient satisfaction, whether they underwent a basic office evaluation or an office evaluation with urodynamics. Now, that's not to say that there were no differences, because there were some differences. So interestingly, the clinical diagnosis changed in 50% of the patients that underwent urodynamics. So 14% of the patients had their treatment plan changed, and 6% received a different type of mid-urethral sling. But those changes did not necessarily result in better outcomes, because there was just no difference in the groups that, regardless of what the physician felt. And I think we all know that. We all have this idea in our minds that, well, a patient with, DO, I'm not going to do this, or a patient that doesn't have, a low leak point pressure, then I might do this procedure. But it just did not pan out to show that even though you had that information, it didn't make those patients do any better. So what have we learned from all of these multi-center incontinence studies? I think that over that 10 years, what we've learned, and we can tell people, is that patients are willing to be randomized to surgeries. I mean, a lot of people question whether that could even happen. And surgeons were, by and large, willing to standardize their outcomes and procedures if brought into the same room. It takes time, for everybody to agree, but it can be done. And standardized multi-center urodynamics can be performed with significant quality control measures, and you can have good inter-rater reliability of how those are both performed and interpreted. But these studies take time, money. And a big problem, just like the birch and the sling, everybody argues, well, those aren't even operations that are done anymore. And so they can sometimes be outdated by the time they are completed with the way technology is developing. They may not be generalizable to the population, which tends to be a much more diverse population, because you do have to narrow your cohorts in order to make, to be specific about what you're looking at. But what kind of level one evidence were we able to obtain? We did obtain level one evidence that the autologous fascial pubovaginal sling is superior to the birch in resolving urinary incontinence, stress predominant urinary incontinence in women at 2 years, and that's maintained up to 5 years. We were able to show that the transobturator mid-urethral sling is equivalent to the retropubic sling for objective success rates. And we were able to demonstrate the preoperative urodynamics in a specific set of women with stress predominant incontinence who have not been operated on before. Does not add any value to the standardized office evaluation. We've learned that in terms of future studies, we've learned that success rates vary significantly depending on how we define success and how we measure it. And that even the ways that we are measuring it clearly are not measuring it the same way women are measuring it, because women's satisfaction rates are high and their quality of life improves in spite of the data that would suggest that they're failing over time. So we are still in search of that holy grail for how to measure success, and we're going to have to keep looking, and whether or not it's simply asking the patient with one, some argue just a generalized statement of improvement and satisfaction, and that should be enough. I don't know. I'm not really ready to say that myself. We do know that failure rates increase over time, and quality of life improvement, patient satisfaction seem to be stable, and that there's really a lack of correlation between the physician and patient outcomes that begs the question, how should we measure what we're doing? And so with that, I'll stop and take any questions that you all have.